Umbilical cord prolapse. RCOG Guideline number 50, November 2014. Introduction and Background Epidemiology. Cord prolapse has been defined as the descent of the umbilical cord through the cervix alongside, occult, or past, overt, the presenting part in the presence of ruptured membranes. Cord presentation is the presence of the umbilical cord between the fetal presenting part and the cervix, with or without intact membranes. The overall incidence of cord prolapse ranges from 0.1 to 0.6%. In the case of breech presentation, the incidence is higher at 1%. The incidence is influenced by population characteristics and is higher when there is a greater percentage of multiple gestations. Clinical issues. What factors are associated with a higher chance of cord prolapse? Clinicians need to be aware of several clinical factors associated with umbilical cord prolapse. Table number 1. Associations with cord prolapse and cord presentation. General. Multiparity. Low birth weight of less than 2.5 kilograms. Preterm labor of less than 37 plus weeks. Fetal congenital anomalies. Breech presentation. Transverse, oblique, and unstable lie. Second twin. Polyhydramnios. Unengaged presenting part. Low-lying placenta. Unstable lie is when the longitudinal axis of the fetus lie is changing repeatedly after 37 weeks. Procedure related. Artificial rupture of membranes with high presenting part. Vaginal manipulation of the fetus with ruptured membranes. External cephalic version during procedure. Internal podalic version. Stabilizing induction of labor. Insertion of intrauterine pressure transducer. Large balloon catheter induction of labor. Can cord presentation be detected antenatally? Routine ultrasound examination is not sufficiently sensitive or specific for identification of cord presentation antenatally and should not be performed to predict increased probability of cord prolapse unless in the context of a research setting. Selective ultrasound screening can be considered for women with breech presentation at term who are considering vaginal birth. Can cord prolapse or its effects be avoided? With transverse, oblique, or unstable lie, Elective admission to hospital after 37 weeks of gestation should be discussed, and women in the community should be advised to present urgently if there are signs of labor or suspicion of membrane rupture. Women with non-cephalic presentations and preterm premature rupture of membranes should be recommended inpatient care. Artificial membrane rupture should be avoided whenever possible if the presenting part is mobile and/or high. If it becomes necessary to rupture the membranes with the high presenting part, this should be performed with arrangements in place for immediate cesarean section. Upward pressure on the presenting part should be kept to a minimum in women during vaginal examination and other obstetric interventions in the context of ruptured membranes because of the risk of upward displacement of the presenting part and cord prolapse. Rupture of membranes should be avoided if on vaginal examination the cord is felt below the presenting part. When cord presentation is diagnosed in established labor, cesarean section is usually indicated. When should cord prolapse be suspected? Cord presentation or prolapse should be excluded at every vaginal examination in labor and after spontaneous rupture of membranes if risk factors are present. In addition to the national guidance for fetal heart rate monitoring in labor, the fetal heart rate should be auscultated after every vaginal examination in labor and after spontaneous membrane rupture. Cord prolapse should be suspected when there is an abnormal fetal heart rate pattern, especially if such changes commence soon after membrane rupture, either spontaneous or artificial. Speculum and/or digital vaginal examination should be performed when cord prolapse is suspected. When spontaneous rupture of membranes occurs, if there is normal fetal heart rate monitoring and there are no risk factors for cord prolapse, then a routine vaginal examination is not indicated. What is the optimal initial management of cord prolapse in a fully equipped hospital setting? When cord prolapse is diagnosed before full dilatation, assistance should be immediately called and preparations made for immediate birth in theater. There are no insufficient data to evaluate manual replacement of the prolapse cord above the presenting part to allow continuation of labor. This practice is not recommended. To prevent vasospasm, there should be a minimal handling of loops of cord lying outside the vagina. To prevent cord compression, it is recommended that the presenting part be elevated either manually or by filling the urinary bladder. Elevation of the presenting part is thought to reduce pressure on the umbilical cord and prevent vascular occlusion. Manual elevation is achieved by inserting 2 fingers of a gloved hand into the vagina and pushing the presenting part upwards. A variation is to remove the hand from the vagina once the presenting part is above the pelvic brim and apply continuous suprapubic pressure upwards. Manual elevation is achieved by inserting 2 fingers of a gloved hand into the vagina and pushing the presenting part upwards. A variation is to remove the hand from the vagina once the presenting part is above the pelvic brim and apply continuous suprapubic pressure upwards. Excessive displacement may encourage more cord to prolapse. If the diagnosis to birth interval is likely to be prolonged, elevation through bladder filling may be more practical. Bladder filling can be achieved quickly by inserting the end of a blood-giving set into a Foley catheter. The catheter should be clamped once 500 to 750 milliliters have been instilled. It is essential to empty the bladder again just before any attempt to assist birth, be it vaginal or cesarean section. Cord compression can be further reduced by the mother adopting the knee chest or left lateral, preferably with head down and pillow under the left hip position. Tocolysis can be considered while preparing for cesarean section if there are persistent fetal heart rate abnormalities after attempts to prevent compression mechanically, particularly when birth is likely to be delayed. Tocolysis has been used to reduce contractions and limit bradycardia, including in women with cord prolapse. The suggested tocolytic regimen is terbutaline 0.25 milligrams subcutaneously. Although the measures described above are potentially useful during preparations for birth, they must not result in unnecessary delay. What is the optimal mode of birth with cord prolapse? Cesarean section is a recommended mode of delivery in cases of cord prolapse when vaginal birth is not imminent in order to prevent hypoxic acidosis. A Category 1 cesarean section should be performed with the aim of achieving birth within 30 minutes or less if the cord prolapse is associated with a suspicious or pathological fetal heart rate pattern, but without compromising maternal safety. Category 2 cesarean birth can be considered for women in whom the fetal heart rate pattern is normal, but continuous assessment of the fetal heart trace is essential. If the cardiotachograph or CTG becomes abnormal, recategorization to Category 1 birth should immediately be considered. Discussion with the anesthetist should take place to decide on the appropriate form of anesthesia. Regional anesthesia can be considered in consultation with an experienced anesthetist. Verbal consent is satisfactory for Category 1 cesarean section. Vaginal birth in most cases operative can be attempted at full dilatation if it is anticipated that birth would be accomplished quickly and safely using standard techniques and take care to avoid impingement of the cord when possible. Breech extraction is appropriate under some circumstances, for example, after internal podalic version for a second twin. A practitioner competent in the resuscitation of the newborn should attend all births that follow cord prolapse. Paired cord blood samples should be taken for pH and base excess measurements.
Neonates born alive after cord prolapse are highly likely to require resuscitation, as evidenced by a high rate of low APGAR scores, 21% at 1 minute and 7% at 5 minutes.
What is the optimal management in community settings? Midwives should assess the risk of cord prolapse for women requesting home birth or birth in centers without facilities for immediate cesarean section and at the start of labor in the community. Women with known cord prolapse should be advised by telephone to assume the knee-chest face-down position while waiting for hospital transfer. During emergency ambulance transfer, the knee-chest position is potentially unsafe, and the exaggerated Sims position, or the left lateral with pillow under hip, should be used. All women with cord prolapse should be advised to be transferred to the nearest consultant-led unit for birth unless an immediate vaginal examination by a competent professional reveals that a spontaneous vaginal birth is imminent. The presenting part should be elevated during transfer, either manually or by using bladder distension. It is recommended that community midwives carry a Foley catheter for this purpose and equipment for fluid infusion. To prevent vasospasm, there should be minimal handling of loops of cord lying outside the vagina.
Perinatal mortality is increased by more than tenfold when cord prolapse occurs outside hospital compared to inside the hospital, and neonatal morbidity is also increased in this circumstance.
What is the optimal management of cord prolapse at the threshold of viability? Expectant management should be discussed for cord prolapse complicating pregnancies with a gestational age at the threshold of viability of 23 plus to 24 plus 6 weeks. Clinicians should be aware that there is no evidence to support replacement of the cord into the uterus when prolapse occurs at or before the threshold of viability. Women should be counseled on both continuation and termination of pregnancy following cord prolapse at the threshold of viability. Should delayed cord clamping or DCC be used after cord prolapse? Delayed cord clamping can be considered if a baby is uncompromised at birth. Immediate resuscitation should take priority over delayed cord clamping when the baby is unwell at birth.
Clinical governance. Explanation of events. An opportunity to discuss the events should be offered to women, possibly with her companions in labor, at a mutually convenient time. After obstetric emergencies, women can be psychologically affected by postnatal depression, post-traumatic stress disorder, or fear of further childbirth. Women with cord prolapse and those who undergo urgent transfer to hospital might be particularly vulnerable to emotional problems. Training. All staff involved in maternity care should receive training in the management of obstetric emergencies, including the management of cord prolapse. Training for cord prolapse should be multidisciplinary and include team rehearsals. Clinical incident reporting. Clinical incident forms should be submitted for all cases of cord prolapse. Documentation. Pre-formatted sheets should be considered for the recording of clinical events related to cord prolapse.